I will speak about an important clinical topic, which is the septic conditions. أولا, septic conditions, it includes a lot of clinical entities and a lot of clinical concepts. I will speak about the difference between each of them. First of all, among the septic conditions is, and the simplest form is the bacteremia. In general, the bacteremia is the presence of bacteria in the blood stream. Usually in small amounts, and the bacteremia may be transient, may be intermittent, or may be persistent, depending on how frequent it enters and in what amounts or which amounts the bacteria enter the blood stream. But it's usually the bacteria in the bloodstream in bacteremia is present in small amounts, and it enters the blood from small colonies present in a certain tissue or in an organ. This is the bacteremia, and as I mentioned, may be transient, which is characterized by the presence of small number of bacteria in the blood for a short period of time, and then it disappears. The intermittent, the bacteria enters the blood in an intermittent form, that is on and off. On and off, it enters the bloodstream, and then it's cleared, and then another shower of bacteria enters. This is the intermittent bacteremia. And then the persistent bacteremia is characterized by the presence of bacteria in the bloodstream persistently. And all of these states of bacteremia, whether the intermittent or the transient or the persistent bacteremia, usually it's a microbiological diagnosis, and it is without clinically significant effects. That's why we call it bacteremia. When the bacteremia increases and becomes clinically significant, we call it septicemia. So septicemia is a clinically significant form of bacteremia. It's a more severe form of bacteremia, which is associated with fever and toxemia and some form of systemic response or systemic reaction. So there's fever, there is toxemia, and there is some sort of or some source of documented infection present in some tissue or in some organ, or maybe a systemic form of fever, like in, for example, salmonellosis or in shigellosis or in brucellosis. These are systemic fevers with systemic response. It's not characterized by the presence of infection in a certain tissue, the respiratory tract or the urinary tract or the gastrointestinal tract, for example, or the central nervous system. So the septicemia is a clinically significant form of bacteremia, which is associated with the fever and toxemia and systemic response with systemic manifestations. And it's usually due to the presence of bacteria in large numbers with multiplication of bacteria in the bloodstream. When the bacteria in the bloodstream increase in number and they multiply in the bloodstream associated with their toxins, this is called septicemia. And then we have what we call the more severe form of septicemia, which is the sepsis or the septic state, which is due to reaction of the immune system to the infection, which affects the different tissues and organs with systemic manifestations. And that's why it is the sepsis or the septic state. When there is a septic state, this is a more severe form of septicemia or an advanced form of septicemia. We call it the septic state. And it is, in short, the combination of what we call the SIRS or the systemic inflammatory response syndrome, together with documented infection. So the presence of a documented infection a certain infection, certain source of infection in the body, for example, in the respiratory tract, in the skin, in the gastrointestinal tract, in the nervous system, the central nervous system, in the subcutaneous tissue, there is some source of infection in some tissue or in some organ, and then this associated with a bloodstream spread of infection together with systemic inflammatory response syndrome, or what we call the SIRS syndrome. This is called the, when the infection is associated with the SIRS syndrome, we call it the septic state. And the septic state, if it is not put under control, it enters or it advances into the septic shock. When there is toxic damage to the endothelium, there is multiple organ failure, and the shock manifestations start to appear, complicating the septic condition. So the association of documented infection with SIRS syndrome and multiple organ failure, this is the classic three features of what we call the septic shock. And this is the ultimate end result of, and the most drastic complication of any sepsis or septic state affecting the human body. This is the difference between bacteremia and septicemia and septic condition or septic state, and the end result, which is the septic shock. And then we have another important definition, which is the toxemia. Toxemia is the presence of the bacteria and their toxins in the bloodstreams. Whether they are the extoxins, that is the toxins secreted by the or excreted by the bacterium, what we call the extoxin producing bacterium, or endotoxemia, that is the toxins which are present within the cell wall of the bacteria itself. So whether it is exotoxins, bacteria with exotoxins, or endotoxins, we call it toxemia. And it expresses the presence of toxins in the blood, bacteria with their toxins in the bloodstream, of course, with clinical manifestations of fever and toxic state. There is a toxic, earthy-looking patient. There is fever. There is. So this is the definition of toxemia, or exotoxemia. And we have to differentiate between bacterial, by the way, we have to differentiate between bacterial endotoxemia and, or what we call high dose endotoxemia, due to the presence of the high level of endotoxin bound bacteria in the bloodstream. And the endotoxins are usually lipopolysaccharides in chemical or in chemistry. This is what we call the high dose endotoxemia, or the bacterial endotoxemia, to be differentiated from what we call the low dose endotoxemia or the metabolic endotoxemia, which is associated with obesity, or what we call obesity associated inflammation, characterized by entrance of high levels of lipopolysaccharides into the bloodstream from the intestinal epithelium. So this is what we call obesity-associated inflammation with elevation of plasma lipopolysaccharides, and this is, we call it the metabolic endotoxemia, or the low-dose endotoxemia. So the metabolic endotoxemia is different from the septic or the infectious or the bacterial endotoxemia, which we call it the high-dose endotoxemia. So I have to differentiate between these clinical definitions or clinical states, the metabolic endotoxemia and the bacterial endotoxemia. This is to be considered among the other septic conditions which are considered differentially between epidemiologists, microbiologists, and the clinicians, even in clinical infectious diseases, and in clinical epidemiology, and how they call and how they define these conditions precisely. This is the difference between the bacteremia, septicemia, septic state, and septic shock and toxemia. Now it's clear the difference between what are the difference between these clinical conditions or clinical concepts. The sepsis in general, it is a potentially life-threatening condition. It's potentially life-threatening condition, especially as I mentioned, the bloodstream infections, the septicemias, because they are associated with life-threatening conditions and increase the morbidity and increase mortality. And patients with septicemia usually need admission into the ICU or the intensive care unit for treatment of the septic condition and the septicemia before they advance and gets complicated by more severe septic status and septic shock, which is a very severe clinical condition and is the ultimate end result of any septicemia if not treated properly. That's why any patient with septicemia is considered as a clinical state with life-threatening state or life-threatening condition. And as I mentioned, it is due to the overreaction of the immune system to the presence of infection in the body. This is very important to we have to consider, and we have to understand sorry for the interruption. And we have to consider the presence of a serious infection, which may be a source of bacteria and microcolonies of bacteria in some tissue or in some organ, which seeds into the blood and causes this. And this septicemia is more frequent, and the severe septic conditions and septic more frequent in patients who are immunocompromised and in patients who are having problems with their immunity, especially patients with chronic disease conditions like uncontrolled diabetes, chronic renal failure, chronic liver disease, patients with cancer, patients on certain drugs like immunosuppressants, or patients on cancer treatments, chemotherapy, biologic therapy, etc. These patients are at risk for development of serious septic complications, septicemias, and septic shock. So we have to always expect the septicemias in such patient categories, or what we call the high-risk patients who might get the severe septic states, septicemias, and septic shock. But anyway, sepsis might develop especially in the respiratory tract, or start in the respiratory tract in the form of upper respiratory infections or lower respiratory infections. The most severe lower respiratory infection, of course, is the pneumonias with all its types. The pneumonias, community-acquired pneumonias, the nosocomial pneumonias or the hospital-acquired pneumonias, the ventilator-acquired pneumonias, the atypical pneumonias, the pneumonias in the occupational pneumonias, the pneumonias in the immunocompromised patients. These are all categories of pneumonias or lung infection of the lung tissue, or the lower respiratory tract infections in general. The most common is the pneumonias, whether the lobar pneumonia or the bronchopneumonias, or the pneumonitis, or whatever the clinical subcategory of this lower respiratory tract infection. But the most common and most severe is pneumonias, الالتهابات الرئوية. This is the most common type of infections which affect human beings. And of course, the most common cause of respiratory infections, upper respiratory, is more common than lower respiratory infections, luckily enough, like the flu, like the influenza with all its types, like the para-influenza infections, like respiratory syncytial viral infections, which cause upper respiratory, common cold, the rhinoviruses. These are viruses which might cause upper respiratory infections, which is the most common form of infections affecting human beings, as we know. especially the influenza, para-influenza, and the flu or the common cold. And these are usually viral in etiology, not bacteria. They might be complicated by secondary bacterial infections, but they are, in most of the cases, start as viral respiratory tract infections or viral upper respiratory tract infections, which might be complicated, as I mentioned, by lower respiratory tract involvement and getting complicated by viral pneumonias or secondary bacterial pneumonias like staph pneumonias, Haemophilus influenza pneumonias, or Streptococcus pneumoniae, or other types, that's pneumococcal pneumonias, and other types of pneumonias, depending on the basic background and the clinical phenotype of the patient, and whether it is community acquired or what we call the CAP pneumonia, or hospital acquired pneumonias or nosocomial pneumonias, or the third common, which is the ventilator-associated pneumonias. These are the respiratory infections, and they might be viral, they might be bacterial, they might be even caused by opportunistic infections or fungal or that's mycotic pneumonias, or might be even other parasitic or protozoal causes of pneumonias. But the most common is the bacterial and the viral respiratory infections, whether the upper or the lower respiratory tract. And then after the respiratory infections, next common is the gastrointestinal infections, including the non-specific infectious gastroenteritis and infectious diarrheas, which is the most common form of gastrointestinal infections, or more specific fevers involving or starting in the gastrointestinal tract, like the salmonellosis in general, typhoid and paratyphoid, and shigellosis, that's Shigella infections, and other causes of gastrointestinal infections like the Yersinia and like the rotavirus, and so there is a lot of and E. coli, of course, with all its causing organisms, the enteropathogenic, the enterotoxic E. coli, and the invasive E. coli. So the Shigella, Salmonella, and E. coli are the most common bacterial causes of gastrointestinal infections, and then come other bacterial causes and viral causes, as I mentioned, the rotavirus and the Yersinia enterocolitica and the other organisms which might cause, and of course the protozoal, including the entamoeba and the giardia and all of these. These are organisms which might cause gastrointestinal infections. And this is the next common after respiratory tract infections. And then we have the urinary tract infections. This is the third common form of organ or tissue infections. The infections starting in the urinary tract, whether in the kidney, pyelitis, or in the ureters, urethritis, or in the urinary bladder, cystitis. And the most common form is the pyelonephritis, as we all know, which is infection involving the pelvis of the kidney and the upper ureter. But also the lower urinary tract infections, which are common in ladies and in women, the urethritis and cystitis infections, especially in women. But also it can occur in men. Especially with obstructive causes, like people with calcular uropathy or obstructive uropathy, calcular urinary disease, or patients with foreign body or catheter-related infections in the urinary tract, or infections associated with prostatic hypertrophy in men. These are all causes of obstructions, because obstructive uropathy encourages the occurrence of urinary tract infections, and we should always look for obstructive causes, commonly foreign body, stone, tumor, catheter, prostate, in patients with which predispose to UT infections. So these are the cases of urinary tract infections, which also might be complicated by bloodstream infections or septicemias, which I talked about. We should manage these conditions, the respiratory or the gastrointestinal or the urinary tract, because they might be complicated, they might be changed from being local infection to a more systemic form of infection when the organism enters the bloodstream, as I mentioned at the beginning, as causes of septicemias. So, because these tissues which are, or the bacteria which are present as colonies in the start localized in one tissue or one organ, like in the start in the respiratory tract, or in the as pneumonia, or in the gastrointestinal tract as enteritis or enterocolitis, or in the urinary tract as pyelonephritis, they might get complicated by septicemia when the organism enters the bloodstream. And it's usually, of course, the bacterial causes. There is no viral septicemia. It's usually when the virus enters the bloodstream, we call it viremia. This is different. That is the presence of virus in the bloodstream. But usually, when we talk about septicemias or toxemias or bacteremia, of course, it is the presence of bacteria and their toxins in the bloodstream, which is the usual cause of septic shock as the ultimate end complication or terminal complication of severe infections affecting the blood streams, whether by gram-positive bacteria or gram-negative bacteria. That's why we have gram-positive septicemia and gram-negative septicemia, and also we might get anaerobic septicemia caused by presence of anaerobic bacteria in the blood stream. That's why we have, in such conditions, that the most important tool which we have to do, or as a diagnostic tool, is to do cultures. Cultures from tissues, and that's tissue culture from, for example, from the respiratory tract by throat swab, or by from the mouth swab, or sputum culture, or culture of the stools if there's GI infections. Gastroenteritis, we have to make stool culture. We have to make urine culture if there is suspected urinary tract infection. After the simple urinalysis, proceed to we find pyuria, we have to proceed to do urine culture. And then if there is suspicion of invasion of the bloodstream by bacteria, whether gram-positive bacteria or gram-negative or anaerobic, we have to do blood culture. And if there is still suspicion and there is a negative blood culture, we have to take sample from the bone marrow, that's bone marrow aspirate, to spot the organism in the bone marrow, especially in cases of intermittent or on and off bacteremia, in which the focus or the colony of bacteria is present in the bone marrow and it enters the bloodstream intermittently. So in such conditions, we have to do also, in addition to blood cultures, and we have to do repeated blood cultures, for example, every day or daily for 3 days, and then maybe even weekly or fortnightly, depending on the underlying possible suspicious organism and the suspicious fever. Is it a specific fever, like, for example, enteric fever, typhoid or paratyphoid, or brucellosis, or maybe also tuberculosis, or maybe all these conditions, we should do a culture in order to cultivate the organism responsible for the infectious state or this infection or the possible infection when we investigate for infection, whether localized or a systemic form of infection, as I mentioned. So this is the also don't forget the endocarditis as a serious form of infection affecting the endocardium of the heart in patients with predisposed conditions, with valvular heart disease or congenital heart disease or prosthetic cardiac valves. In all these conditions, they might get complicated by infection of the endocardium, which is characterized by toxemia and bacteremia also. and by the presence of infectious emboli from vegetations on the septic vegetations on the cardiac valves. So there is a combination of embolization and toxemia in such patients of endocarditis, what we call infective endocarditis, which is a severe cardiac infection with also life-threatening complications like arrhythmias, like heart failure, like death, like systemic complications, emboli into the brain, emboli into the spleen, emboli into the liver. So this infective endocarditis, which is serious cardiac infection, must be treated vigorously and seriously as a life-threatening cardiac infection, especially, as I mentioned, in patients who are susceptible to get such serious clinical cardiac infection affecting the cardiac endocardium, which is the infective endocarditis. Of course, we have to differentiate it from what we call non-infective or verrucous endocarditis, which is another form of inflammation of the endocardium of the heart due to non-septic causes or non-infectious cause, as happens in, for example, autoimmune diseases like in systemic lupus erythematosus, what we call Lippmann-Sachs endocarditis, to be differentiated from infectious or infective endocarditis. Another serious infection also is which might be complicated by serious septic conditions and septicemias is the meningitis, which is inflammation, which is a central nervous system inflammation. With all its types, all the spectrum of meningitis, the septic meningitis and the aseptic meningitis, and of course, whether it is associated with encephalitis or what we call meningoencephalitis, or just that's inflammation of the substance of the brain or of the brain tissue, or just inflammation of the meninges, the arachnoid and the dura and the pyometer, which is the layers of the meninges surrounding the brain. When it gets inflamed, we call it meningitis, of course. And there is many different microbiological or clinical microbiological types, the septic and the aseptic meningitis. Of course, the most severe, which is associated with septicemia and toxemia, and the patient might get also serious septic complications, is the septic meningitis, especially the meningococcal meningitis. Which is a septic bacterial meningitis, because we have also the viral meningitis, and we have cryptococcal meningitis, fungal meningitis due to fungi, and also we have protozoal meningitis and parasitic meningitis, drug-induced meningitis. These are all causes of meningitis, but the most severe, which is treated with septic conditions and septic complications, is the meningococcal meningitis, اللي هو الالتهاب الأغشية السحائية أو الالتهاب السحائي للدماغ أو البرين. And it's also life-threatening conditions with increased morbidity and increased mortality. So it's one of the serious infections in the human body, which we should treat vigorously and early as possible, and should be aggressively treated. The meningitis should be aggressively treated. The endocarditis should be aggressively treated. The pneumonias should be aggressively treated. The septicemia should be aggressively treated and better to be managed in intensive care unit, as I mentioned, because the patient needs fluids, the patient needs a combination of antibiotics. At least 2 or 3 antibiotics should be given parenterally. The rules here to treat serious infections, including septicemias, including endocarditis, including meningitis, is to give the patient a combination of antibiotics, usually bactericidal antibiotics, 2 or 3, by intravenous route, or combination of intravenous and intramuscular routes at the beginning, at least for the first 1 or 2 weeks, and then we change to continue with oral antibacterial drugs or antibiotics, depending on the underlying condition and depending on the underlying causative organism detected in each particular individual patient. This is the rule in management of the serious septic conditions, is to put the patient under close observation in the intensive care unit, is to isolate the patient, is to, of course, after doing the blood cultures and the different investigations, even to check the systemic response, to do liver function after the CBC is very important. The ESR, the C-reactive protein, the high sensitivity C-reactive protein, to do the serology, to do the liver serology for detection of organisms, and for detection of toxins in the bloodstream, to do a blood culture, to do liver function tests, to do kidney function tests, very important to detect any complications affecting the liver or affecting the kidney, to do electrolytes, to do blood urea nitrogen, to do sodium and potassium, to do acid-base status, arterial blood gas analysis, for detection of any impending shock, to monitor the vital signs, the blood pressure, the pulse, the temperature, to monitor the oxygen saturation, to monitor the state of consciousness, to monitor the urine output. All of these points are important to monitor clinically and to start aggressive treatment by giving the patients management of shock by intravenous fluid resuscitation, as we all know, the saline, the dextrose, etc. In order to do what we call hemodynamic support of the patient. The patient also, if have gone into shock, we have to give him the proper vasopressors and the proper inotropes to maintain the circulation and to maintain the blood pressure and to maintain the cardiac output and to support the cardiovascular status. And then this is the supportive supportive or symptomatic treatment. And then the more specific treatment is to give the patient intravenous antibiotics as a combination of antibiotics. And usually we give the antibiotics in combination. The rules is 3 rules. It's combination, 2 or 3 drugs, and they should be or must be given intravenous, and they must be all bactericidal antibiotics. We don't use the bacteriostatic antibiotics in such severe cases of septicemias or septic shock. We have to give 2 or 3 antibiotics to cover positive, gram-positive, gram-negative, and anaerobic bacteria. We might give in the combination 3rd generation or 4th generation cephalosporins. This is vital and very important in most of the cases, like the cefotaxime or the ceftazidime or ceftriaxone. It's one of the strongest. These 3 which I mentioned are among the strongest cephalosporins which are used in severe septic states, especially ceftazidime and cefotaxime and the cefoperazone. So we have to give usually beta-lactam 3rd generation. We might also combine with, in some cases, include in the regimen aminoglycosides, especially the nepsin or netilmicin or the topramycin. So the addition, and these are the most common, the topramycin and the nitromycin, are the or the classic garamycin, are the 3 most common aminoglycosides which might be included in combination with 3rd generation cephalosporin in such cases. And also we might add in some cases intravenous metronidazole if there is a suspicion of an anaerobic infection also. Or we might give also the one which covers many infections, especially the MRSA strains, which is the vancomycin. Intravenous vancomycin is a very good choice in many selected cases, especially in cases which doesn't respond to primitive regimens like cephalosporin with aminoglycoside. We might have to add vancomycin, intravenous vancomycin in such cases, or the other also antibiotics which are recently also discovered in the for treatment of and as beta-lactam antibiotics, especially for the gram-negative infections, as I mentioned, especially for cases complicating ventilator-associated pneumonias or hospital-acquired pneumonias. There are now new antibiotics belonging to the beta-lactam group, belonging to the epinams and meropenams and the tazobactams, and these are new, and their derivatives, the new derivatives, which can be included in the antibiotic regimens when we are managing such cases of serious septic conditions. This is the we have to monitor the patient. We have to evaluate every now and then. The under observation is the art of management and the art of practice in such cases, as it is the general rule in clinical medicine in general, is to wait and see, is to put a patient under observation, is to observe clinically by clinical parameters, by microbiological parameters, by biochemical parameters, by following the blood picture, by the RBCs, the white BCs, the platelets, all of these things are important to follow in order to follow the course of the infection, and in order to follow up also the effect of treatments given by doing these investigations. So the investigations is to follow the infection, which is the original disease, and to follow the treatment which you are giving to that patient in the ICU. And then after the patient gets stabilized, which might take a few days or 1 week or 2 weeks, so we might transfer the patient from the ICU setting to the general medical ward for further management after that, before being discharged, depending on also the underlying clinical condition causing the septic state or the sepsis in this patient. This is the and then in some cases we might have to put the patient, for example, on a ventilation or mechanical ventilation or that's respiratory ventilation. This depends on how the condition of the patient gets deteriorating, or the patient gets complications regarding the respiratory tract, or had got respiratory failure, or the patient also might get DIC, septic condition, might be complicated by pancreatitis, acute pancreatitis, and these are severe, serious complications of the septic shock or the septic states. The patient might get a disseminated intravascular coagulopathy, which is hematologic failure of the blood, with thrombocytopenia, with anemia, with bleedings, with acute bleeding, with microthrombi. That is what we call DIC. So septic shock might be complicated by DIC. Septic shock might be complicated by SARS, by acute respiratory distress syndrome. So, and might get complicated by non-cardiogenic pulmonary edema. So these are the complications of septic shock if not properly managed. So look for respirations. That's why we should monitor the blood gases. That's why we should monitor the acid-base balance status every few hours daily, depending on the clinical condition of the patient. We should monitor the blood for any DIC. We should monitor the pancreas, because acute pancreatitis also is a common complication. We should monitor the kidney, because acute renal failure might happen in such patients due to pre-renal factors. So these are the possible complications affecting the liver, affecting the kidney, affecting the respiratory tract, the respiratory system, affecting the complicating septic shock and septic state. So this should be treated expectedly. That is, the treating physician, the clinician in the ICU, or the clinicians attending such cases as a team, they should put into consideration what are the possible complications which might happen, and then they should act rather than react. That is, act to prevent the complications, not to wait for the complications and then react to manage the complications. So they should act expectedly. يعني يشتغلوا متوقعين اللي ممكن يحصل كcomplications للseptic state in every particular patient or in every individual case. As I mentioned, this depends on the underlying condition, the underlying state, whether this happens in a healthy patient or in a patient with underlying chronic disease, diabetic patient, or patient with chronic renal failure, patient with chronic liver disease like chronic liver cirrhosis or chronic hepatitis or whatever, patients with cancer, underlying cancer, patients with each category of patients, they have their general different imagination, and they have different overview depending on what we call the clinical phenotype of every individual case, which has got this infectious complication, the septic condition or the septic state. So this is in general the definitions and how to approach the patient with septic condition or septic state. And as I mentioned, don't forget the source of infection. Trace for a source of infection in the skin and in the subcutaneous tissue, either skin infection, carbuncle, or abscess, or cellulitis, or which started the septic complication. Or check the respiratory tract, chest X-ray, check the urinary tract, do urine analysis simply, check the gastrointestinal tract, do stool examination, stool culture, etc. Check for specific fever like typhoid fever, like Shigella, like Brucella, like infectious mononucleosis. Check what is the possible underlying febrile illness which caused this and infectious process which has started these septic complications, bacteremia, the septicemia, the septic status, and the septic shock as the final terminal complication of any severe uncontrolled septicemia or sepsis affecting the human body. Thank you so much for all my colleagues and my students. Beware, the attending clinician should always observe and should always think well. This is very important. It's not enough to have knowledge. The most dangerous clinician is the one who observe and the one who think thoroughly and the one who understand exactly the pathobiology of what is going on to his patient and to every individual case separately. And here we have also to apply the concept of individualization of treatment, or what we call the personalized therapy, even in such cases with infectious disease or febrile illness complicated by septic state, which or any septic condition which I have mentioned in my presentation today. Beware, try to be systematic, try to be systemic, try to be thoughtful, try to be observant. This is my advice to my students and the junior doctors who manage such cases or approach such cases at the beginning in the primary care or in the second or tertiary care after that. Thank you so much, Professor Dr. Tarek Ali.